Hi, everybody. Welcome to our Facebook Live event from Washington University Orthopedics here in St. Louis. My name is Aaron Chamberlain. I'm one of our shoulder and elbow surgeons. And tonight we're going to be talking a little bit about shoulder replacements and some of the issues around shoulder replacements and expectations, what surgery is like, and some rehabilitation education on what it's like to have a shoulder replacement. I'm, as I mentioned, one of 4 or 5 shoulder and elbow surgeons here at the Washington University Orthopedics, and I'm joined tonight by Dr. Ben Zmistowski, who has recently joined our group. So we're excited to have him join our discussion tonight about shoulder replacements. So Ben, welcome. We're glad to have you with us.
Thanks so much for having me, Dr. Chamberlain. I'm excited to get going, joining the group. And talk tonight about shoulder replacements. Hopefully we're able to answer a lot of questions for people about why we do these, how we do them, and what the expectations for a good outcome are. So having that said, why don't we just get into it and start off for why someone might actually consider getting a shoulder replacement. What are the diagnoses that patients typically come in with that leads us to recommending a shoulder replacement or has us consider a shoulder replacement?
It's a great way to start. Most patients that come in who are candidates for shoulder replacement have typically or traditionally have a diagnosis of osteoarthritis or sometimes like rheumatoid arthritis in their shoulder that's really caused the cartilage surfaces to wear down. So they're essentially bone on bone or getting close to being bone on bone. And this is causing a lot of pain and interruption to their life. So oftentimes on x-rays, we'll see this breakdown of the joint. But more importantly, patients are also dealing with a lot of pain that's affecting their ability to function on a daily basis, and they're really having a hard time getting through their work day, or even sometimes sleeping at night. So when we see that patients get to that point of having that degree of pain that's not really getting better with some routine ibuprofen or just kind of taking it easy, then we start to think that a shoulder replacement might be necessary. Sometimes it's for a different type of problem altogether, which is a rotator cuff tear that's not repairable. Sometimes patients have a rotator cuff tear around the shoulder. If it's not repairable, if it's something that's too far gone, so to speak, then sometimes a certain type of shoulder replacement would be helpful for them.
Yeah, I think that's something that actually surprises a lot of our patients when they come in with a rotator cuff tear and it's beyond the point of repair, and it's led to, and it's potentially started to develop some arthritic changes in the shoulder. To discussing shoulder replacement in that population is oftentimes surprising to the patients because it catches them off guard. But I think that does a good job of bringing us to our next point of why would we consider a shoulder replacement in that population, and exactly what is it when we discuss a shoulder replacement, what are we talking about doing?
Yeah, I think it's important to realize there are maybe 2 families of shoulder replacements that we may recommend. The first group of patients I was talking about with arthritis, those patients often are candidates for what we call an anatomic shoulder replacement, where with the ball in the socket in the joint, we're removing the arthritis, the ball that's covered in arthritis, so to speak, and we replace it with a new metal ball that's the same size and shape. And then we accompany that on the socket side with a new plastic socket. So we have a metal ball on a plastic socket that then they can use. It's a nice smooth gliding surface, and that really does a good job of treating the pain. But if they don't have a rotator cuff, where the rotator cuff keeps that ball centered in the socket, if they don't have a rotator cuff, then that ball won't stay centered in the socket, won't function right. And in many cases, that would cause a lot of pain and problems. So in those cases, a regular anatomic shoulder replacement is not the right answer. If they don't have a rotator cuff, we really need to do a reverse shoulder replacement. And we call it reverse because we've reversed the ball and socket orientation. So normally the ball sits in the socket and rotates around in the socket. In this case, we remove the ball out of the way and we bolt a metal ball onto where the socket was. And so the ball's on that side now, and then we create a socket on the ball side. And now the socket rotates around the ball. And so that's why we call it a reverse shoulder replacement. And that's the one that you need if you don't have a rotator cuff that's intact. So, that's typically the kind of the 2 families of shoulder replacements. And so people often say, well, they have a friend who got this type of replacement or that type of replacement. And that's typically the reason why we would choose one over the other, is when there's a rotator cuff tear. sometimes it's hard for people to know if they have a rotator cuff tear. They know they have pain in the shoulder, but maybe Ben, how do you like to look for rotator cuff tears, or how do you know if somebody's got a rotator cuff tear in the shoulder so that you know which type of replacement they might need?
Yeah, I think that's a great question. It's important for us to be able to check on the health of the rotator cuff um, when patients come in, to know if they needed a reverse shoulder replacement or if we're able to do an anatomic shoulder replacement, because we always try to restore the normal anatomy as much as possible, and that's going to give our patients the best chance for a very well functioning shoulder. Both shoulder replacements do very well, but when we can, we want to put in the anatomic shoulder replacement because it's going to give the best chance for good range of motion of the shoulder, strength and function. When I'm looking to see if somebody has a functioning rotator cuff, there are a lot of things that I'm looking for. Oftentimes, you can tell just based upon the x-rays and the pattern of arthritis that patients come in with. If the arthritis is standard osteoarthritis, very rarely is there a concern for rotator cuff tear. If on examining the patient or taking their history, I'm concerned about the potential for rotator cuff damage in that population, I'm going to get an ultrasound to evaluate the rotator cuff further. There are more often patients, it's clear that patients need to have a reverse shoulder replacement based upon the pattern of the arthritis that we see on the x-rays, because like you said, the ball is no longer centered in the socket. And on the x-rays, when somebody has a massive rotator cuff tear that's led to arthritis in the joint, or arthropathy as we call it, it has shifted up on the x-rays. And that's a clear telltale sign that that patient is not going to do well with an anatomic or normal shoulder replacement, and they're going to need a reverse shoulder replacement.
So are you saying then in those cases where on the x-ray that ball has moved up a lot, are you saying that you can make a determination just on the x-ray that there's a rotator cuff tear, that you don't need an order an MRI to look at that?
No, that's exactly right. That when we see that the ball has shifted up like that, that tells us that that patient does not need further workup to determine that they have a rotator cuff tear, and they would benefit from a reverse shoulder replacement rather than an anatomic shoulder replacement.
Now, if you have a patient that comes in, are there alternatives to a replacement? So sometimes a replacement sounds like a big step. So if somebody's, maybe not ready for that step, are there alternatives, or what would you recommend to somebody who may want to think about something other than surgery for the time being?
Right. In all of our patients that we see with these problems that would potentially need a shoulder replacement down the road, we attempt to maximize delaying that shoulder replacement as much as possible, because like you said, it's a big deal to have a surgery. It's a major surgery. It's become more routine now, but it does oftentimes require an admission to the hospital and a stay overnight. And there are potential complications anytime we do a surgery like this. So we do try to use our non-operative tools as much as possible. And those consist of things like steroid injections that can either be done in the office or sometimes under x-ray guidance to make sure that it gets into the appropriate spot. We will use physical therapy, especially in the setting of a rotator cuff tear, and see if we can try to improve the mechanics of the shoulder a little bit. And anti-inflammatory medications like ibuprofen, Motrin, when patients are able to tolerate them, can help to bring down the pain. And those things can help to delay the need for a shoulder replacement and help patients that have milder cases of osteoarthritis, rheumatoid arthritis, or these other diagnoses in delaying surgery, sometimes up to years, depending upon how well the response is. But I guess that brings up the next question, Dr. Chamberlain. When is the right time to consider a shoulder replacement? How do you know that you've maximized your non-operative treatment options, and now it's time to take the plunge for a shoulder replacement?
Yeah, that's a question I hear from patients often is, when do we need to do this replacement? And I kind of have a similar philosophy to you, where when in my conversation with patients is we try to discuss kind of the severity, how severely is their pain affecting their ability to function every day. And if it's something they can manage through with some anti-inflammatories, ibuprofen, and modifying some things, and we try to encourage them to put off replacement as long as they can. And really the decision is less to do with, how bad does their x-ray look, or how severe is the arthritis, but it has more to do with how severe the pain is, because the main reason to do the replacement is to treat pain. So if somebody's not having a lot of pain, I think you can delay that surgery as long as you'd like. There really isn't a rush to doing a surgery. We can take this as slow as the patient would like. But if there is, a significant disability where they've gotten to the point where they've tried all of those non-surgical things and they've gotten to a point where they're not able to work or sleep or function like they need to, that's usually when I tell them it's about time to go ahead. And really, like you said, the results from shoulder replacements are now pretty predictably good. We've got a lot of experience under our belts. We do a lot of shoulder replacements here at Washington University, at Barnes Jewish Hospital, and at Barnes Jewish West County, and we've got a great team of nurses that really understand the protocols, and I think overall we can create a good patient experience throughout the surgery, and then also get people to be highly functional after reverse shoulder replacement. So once it gets to that point where their life is being altered, I think we can turn the page and start looking toward improvement with the replacement.
Yeah. In my experience, it seems like the thing that most oftentimes tips patients over the edge is the inability to get a good night's sleep. When it really starts to affect patients' quality of sleep, that's when they really are not able to tolerate the pain anymore. But like you said, there are a lot of things that go into it, and really ultimately, we have to guide the patient into making that decision for themselves, because they're the ones that know how much it's affecting their life.
Yeah.
When we start to talk about shoulder replacement, what do you do specifically to try to make sure that we're matching the patient's anatomy and giving them the correct type of shoulder replacement? Do you have any special techniques to try to make sure that we are putting the replacement in exactly the right spot and recreating their anatomy as much as possible?
That's a great question. So, traditionally, what we've done, many patients want to know, do we have implants that are sized to their size? And most of the sizing that we do traditionally for replacement, any joint replacement, is done in the operating room, where we can directly see the bone and the joint that we're working with. And we have various sizes of heads and stems that go down the bone, and sockets, and we have all those available to us, and we have ways of measuring that in the operating room. And so traditionally, we've used just our experience, where we've had with a lot of experience, where we do hundreds of shoulder replacements a year. We have some good experience under our belt, where we can say, based on our experience, this is the right size and the right position. And it does take some experience, I think, to be able to make those judgments appropriately. But for the most part, the modern day implants and systems allow us to really precisely measure and place the implants that are appropriate for the patient. In addition to that, though, nowadays we have additional technology where we can use the preoperative X-rays and CT scans to load it into software, and then virtually or plan the procedure, where we can look at the CT scan and virtually or with the computer software place the implants or what they would look like on the bone, and make sure we can see, even before we ever enter the operating room, what size of implant we might need and what position might be the best for those patients. And so this is really a revolutionary thing that we use more and more commonly in shoulder surgery to be able to plan, especially complex cases where we might need to do a little more thinking and planning on types of implants. But I know we've all had some experience with it. Ben, or why don't you fill us in a little bit on your experience with what we call preoperative planning thus far?
Well, I mean, I think it's an important tool, especially patients who have osteoarthritis of the shoulder can get this very unique pattern where the ball is centered to start, and then as the cartilage wears away, as you know, it can wear away the back of the joint more than the front or the center, and you end up losing bone in the back, and that can create a problem where the shoulder is very unstable. Preoperative planning, I find, is most helpful in that situation, where we get a CT scan and we see that the patient has lost bone in the back. Preoperative planning allows us to account for that, because it can be difficult to really detect that in the surgery. But when we're looking at the bone, the patient's specific bone, on the computer before we do the surgery, it allows us to make sure that we selected the right implant to account for that bone loss, and then to make sure that we put that implant in the right position. It allows us to practice putting that implant right where we think it should go virtually, and then recreate that in the operating room. And in very severe cases where there's a lot of bone loss and you feel like the anatomy is really distorted, implant companies have now come out with, we can make guides that we can actually create off of the patient's CT scan and their own bone that we can then use during the surgery to make sure that the implants go exactly where we want. So I think that we have gotten much better about making sure that these implants are in the right place so that they last the patient as long as possible.
Yeah, and I think the real result of that really benefits the patient, right? Because the more precise and the more accurate we can be with placing implants, I think the more reproducibly good the outcomes can be. And so I think over time, with more experience and more precision and accuracy, we're starting to see that patient outcomes are more reliably positive, that we don't have as many outliers where we don't understand why somebody doesn't do as well, but more and more patients are pretty reliably happy with their shoulder replacement. And I think it's this precision, that we can get with experience and with preoperative planning software to really do that. So I think it's an exciting time in shoulder surgery for that, for many reasons, but that being one of the areas where we're really excited about how we can really help patients. So it's a great time for those who need a shoulder. Things have come a long way over the last 10 to 20 years as far as implants and techniques, ways that we can improve things. And so overall, I think things are really in a good spot right now and looking up. Yes. One of the things that we've had some experience with too is that whole experience around the time of surgery. What's the process like to recover? How long do you need to be in the hospital? What's your usual discussion with patients around those areas?
Yeah, like I had mentioned earlier, it's typical that most of our patients will stay one night in the hospital. And that's usually at this point, it's not as much of a concern from a medical standpoint as it is making sure that they're getting up, getting around, rehabbing as well, that the pain is well, that their patient's pain is well controlled, and that there are no medical issues and they recover from the anesthesia well. Usually, I would say most of our patients go home the next day and stay in their sling until their first postoperative visit, doing some gentle exercises to work on the range of motion based upon what type of shoulder replacement that they get. So the hospital process has become much more streamlined. I know that you especially have had more experience with patients who don't like being in the hospital. They don't like being woken up in the middle of the night, either to take medicines or get some blood drawn or their blood pressure checked. And when they're young and healthy, they certainly could be potential candidates for discharging and not the same day and not having to stay in the hospital or outpatient shoulder replacement. What has your experience been with that? And is that something you see in the future?
Yeah, that's a great point. I think this is another one of those areas where I think we've made the patient experience around surgery much improved. And in some cases now with modern pain control techniques where we'll often use a nerve catheter where we numb the arm, and patients go home with a little catheter that delivers numbing medicine, and that stays in there for 2 or 3 days and keeps them comfortable so that even after surgery within a couple of hours, they're very comfortable and they're going to stay comfortable for a couple of days and they really want to go home. And so in those cases, if they're, as you mentioned, healthy and stable on their feet and we don't have a need to monitor anything overnight in the hospital, many of them will request to go home, and we can make that happen now where they'll get all of their educational materials and instructions within the first few hours after surgery and then be able to get them home. And our experience has been pretty positive where patients in those cases, feel more comfortable recovering in their own bed, in their own home. And we want to make sure their families feel comfortable with that as well. And so we do some education around that. But I see this as an area that is probably going to expand a little bit. I think we'll have more opportunity to get people home the same day if that's something they really desire. And the nice thing is with a lot of these shoulder replacements with total shoulders, we're starting activities, day after surgery, exercises for range of motion. We don't want people doing all of the lifting, so no lifting more than a couple of pounds, and we don't want them reaching behind the back. But within a day or two after an anatomic shoulder replacement, we'll have people doing exercises and using their arm. And so I think that really helps people get back to closer to being back to their normal. And really, we kind of baby the shoulder like that for about the first 2 to 3 months in general. I usually tell patients that, they're going to be using their arm increasingly over the first 2 or 3 months. Just, we don't want to do any heavy activity, but after 3 months, people can get back to a little more strenuous activity once the tendon heals that we have to repair at the end of surgery, and things are starting to solidify in the shoulder joint. But after a brief hospital stay, if any, and a couple of months of recovery, usually we're having people get back to most of the activities. But has that been your experience as well, Ben? Or
Yeah, I think I usually tell patients that they're going to get, after they go through the recovery, it can be a little bit painful in the first few weeks, but they're going to be pretty happy that they had the surgery. By the 3-month standpoint, they're probably going to be maybe 65 to 70% as good as they would be with happy with their shoulder. And then it can take up to 2 years to really get to maximize where you're 100% as good as you're going to be. But you're really pretty happy you had the surgery and feeling good with that shoulder and with significantly decreased pain by the 3-month standpoint, and especially by the 6-month standpoint. In that rehab process, for you, what is your role for formal physical therapy? I know patients, that's oftentimes a question is, it can sometimes be a burden to do physical therapy, but they also really enjoy the therapy process and think that they get a lot of benefit from going to physical therapy. What's your role in anatomic shoulder replacement and reverse shoulder replacement for doing physical therapy?
So yeah, great question. And I do think that patients have some, sometimes they come and with some already, some opinions about whether they want to participate in therapy or whether they'd rather not. The good news is with most anatomic shoulder replacements and likely with reverse shoulder replacements, most of the rehab can be done on their own at home. And I think most patients find that as a convenient reality where it's not heavily required that they need to go to therapy or else their outcome will be bad. Most of the time with the techniques that we use, we can help them achieve good outcomes, whether they do the exercises on their own at home or whether they choose to go work with a therapist. And for me, I'm pretty flexible with if somebody has a preference or if I see that they really need a boost with their exercises, then I'll get them in with a therapist. And usually they're able to do that somewhere close to home. Many of our patients travel in from many hours away and they're happy to know they don't have to keep traveling here for therapy. We can make recommendations for therapists somewhere closer to home and they can do that there. But generally, I think that patients recognize that a bulk of this is done on their own and we can supplement that with therapy as they go.
Right. I think that's really an important point to make is that the outcome of shoulder replacement is dependent upon a lot of things, a lot of which is technical, but also heavily reliant on the patient and their involvement in the exercises. And those exercises can help with some guidance from physical therapy, but that doesn't mean very much if the patient isn't participating in those exercises. And that's really what is going to drive their outcome. But definitely in the first few months, physical therapy can be a good augment for a lot of these patients.
Yeah, definitely. And I think, having that discussion with each patient is important, kind of sensing what their preferences are one way or the other. But, one question that comes up often with patients, Ben, is that many people have had other joints that are arthritic. So some people have had hips that are arthritic and they've had a hip replacement and maybe a knee replacement. And they've had some experience with those replacements. They want to know, how does a shoulder replacement compare to that? What's been your experience with how shoulder replacement recovery compares? How does it compare to hip and knee replacement surgery?
It can be very variable and patients have different experiences, but in general, I'd say that the most difficult rehab process is typically a knee replacement. That can be, it's a weight-bearing joint and you're forced to get up and get moving and it can get stiff and that can be very painful. Hip replacement is probably actually one of the easiest joint replacements to recover from. For whatever reason, patients just seem to have a easier time getting up and getting around after a hip replacement, especially with the newer approaches that are used around the hip. And I tell patients that typically, if you have experience with either one of those or maybe both, a shoulder falls somewhere in between there. It's not as difficult as a knee replacement, but it's a little bit harder to recover from a hip replacement. But it is variable from patient to patient. And we use nerve catheters in the shoulder like you touched on, and that can help make the recovery process even easier.
Yeah, I think those are all, I have a similar experience. I don't have a hip or a knee replacement myself, but my patients who do and have a shoulder replacement also kind of tell me the same thing. But you're right, it can be variable. Some people don't need even much pain medication after a shoulder replacement. For maybe a couple of days, they'll take a little bit. And other people might struggle a little bit more. Pain is a variable thing from individual to individual. But I think our approach to that is pretty similar. One other thing that comes up often is patients will say, how long do these last? How long does a shoulder replacement last? What can I expect long term? So what do you usually tell people there?
Again, that's something that can vary a lot from patient to patient, and it also depends upon how active you are and what's the reason that we're doing the surgery. But for the most part, as this technology has become much more modern and has been developed with experience, the implants have been developed and improved upon, we're seeing that these replacements are reliably lasting 12 to 15 years. Reverse shoulder replacements is a newer technology. It's only been available in the United States since 2004, but there are a lot of patients out there with reverse shoulder replacements put in around that time period or earlier in other places that are doing very well and have them continuing to last. So there are a lot of patients who are walking around still with shoulder replacements that are up to 20 years old. And as we have shoulder replacements out there that are wearing out early, we have a lot of experience with revising them or sort of revamping them because they've worn out and they wear out for a variety of reasons. And oftentimes we're able to just change out a couple pieces, not have to redo the whole shoulder replacement. So hopefully, as our technology improves and patients have these for longer and longer, our ability to revise them or provide with an updated shoulder replacement when they do wear out will not be as intensive. And we've gotten better at preserving the patient's own bone so that those shoulder replacements last even longer.
Yeah. Is there anything, so I like to see these outcome studies, with a lot of literature that's out there, and some of the longer term studies show that these implants are lasting longer than the original versions of the implants. And with modern implants and techniques, we're excited about the fact that most of these are lasting upwards of 15 to 20 years and doing a great job of getting pain relief. And I think some of it has to do with how they're used, right? So what types of, how heavily the patient uses that shoulder and whatnot. So in the long term, kind of to wrap things up, what kind of activities can you expect patients to do with their shoulder? Which ones are you comfortable with patients doing, and which ones might you be recommending against for patients with a shoulder replacement?
Yeah, I think we've come a long way in the technology, like you've touched on, and that's allowed us to loosen our restrictions some, as we've seen that these shoulder replacements are lasting a long time. Historically, we've really limited patients to weightlifting or the amount that they can lift with a shoulder replacement because we're concerned about wearing it out earlier. And that's especially true in young patients who are very heavy lifters, active laborers. We do get concerned about wearing out the shoulder faster. But at this point, there's not a lot of restrictions after the patients get out of the 3 to 6 month time point that I'm going to put on them and tell them that they're not going to be able to do with their shoulder, because the whole reason that we're doing the shoulder replacement really is to get them back to the activities that they enjoy doing.
Yeah, I think that's a great point. That's the real purpose of the shoulder replacement, is to get people's pain relieved and get them back to doing what life demands of them. And so, whether that means getting back to work and being able to be productive for the remainder of their working life, or doing activities in recreational sports they love, playing golf and tennis, pickleball is pretty popular now, and, even more contact sports and some lifting as well. All of those things I think are realistic activities to get people back. I'll often recommend against heavy like bodybuilding or weightlifting or things like running a jackhammer or chopping wood with an axe. But most people aren't doing those things, and I think most people are happy to hear about the fact that they can do a wide range of activities and really get pain relief from it. So I think those are some of the main issues we hear from folks and in our conversations with people about shoulder replacements and what to expect. Anything else you want to add?
No, I think we've covered it all. Hopefully, we've given our patients a lot of information and things to think about.
Yeah, and certainly we're available if other questions come up around. We're happy to discuss and chat further. But it's an area we're passionate about and we're excited about, and we love to see patients get better. And shoulder replacement is one of those things that can really help. So if people are in need of it, we're here to help if needed.